Right. We're hot. Oh, yeah. Thanks.
Okay. All right, everyone. If you can hear me out there, we're getting started just to keep things on time. So our next lecture will be given by Dr. Todd Barron. Dr. Barron is a professor of medicine and director of advanced therapeutic endoscopy at UNC. He is an international expert in interventional endoscopy and has written hundreds of papers and multiple books on the topic. He was recognized as a master endoscopist by the ASGE in 2010. He's an excellent person to be educating all of us on ERCP cannulation, and we are very excited and grateful to have him here. Thanks.
Thank you, Anna. And I'd like to thank the course organizers for inviting me to this really amazing course. I'm going to start out with a clean joke, actually. So one that I made up. Okay, so James Bond is visiting the United States, and he's found to have a large esophageal submucosal tumor. So he goes in to have it resected, and right as they're bringing him in to the room, there's a massive earthquake, and they had to cancel his procedure. So at the end of the day, he was shaken but not stirred. Anybody need me to explain that? Catch me outside. How about that? All right. So we're going to talk. All right. So we're going to talk about both cannulation and we're going to talk about sphincterotomy. For this talk, really, I'm going to mostly limit both the cannulation and the sphincterotomy to biliary sphincterotomy. So keep in mind that cannulation is the basic step required for therapeutic ERCP. So obviously, if you can't get in, you can't do anything therapeutically. Consistent, rapid, safe cannulation is one of the most important ERCP skills that you can develop. We know skill level increases with procedural experience. And I'm here to tell you, after doing this for about 30 years, improvement in cannulation skills is really never ending. I don't think you can ever not get better with time and practice. So the first thing to remember is if we're looking at the papilla, so imagine we're looking directly at the papilla. The bile duct is it's one opening that quickly splits into two openings, such that it almost behaves like there are two separate openings, and there's a septum that runs across diagonally. So the bile duct is in the left upper quadrant of the papilla, and the pancreatic duct is on the right lower. So depending on what duct you're trying to get into, you're going to change your position. I like to draw it more in quadrants. So the left upper quadrant is the bile duct, the right lower quadrant is the pancreatic duct. And this just, I keep beating this to death because this is a really, really important concept of where the location is. The other thing about the septum that I mentioned is that there's a reason you can't cannulate the pancreatic duct and say, oh, well, I'm in the pancreas, let me just flip over and get into the bile duct. It's because of that septum that runs across that you can't just simply change. You have to back out of the duct almost completely and then recannulate rather than just say, I'm going to switch over from the pancreas to the bile duct. The other thing is the orientation. So not only does the bile duct start at the left upper, but its trajectory is very, very steep, straight up. So you tend to want to have the scope a little bit below the papilla, or more likely, this is why we use the sphincter tome to cannulate the bile duct, is we can change that direction and bow the sphincter tome up so it's heading toward the bile duct. Conversely, the pancreatic duct is fairly straight back. So you go toward the right lower and you want to kind of go straight back. And notice the scope is a little bit, if you will, higher. So you're looking almost directly across from the papilla. So depending on which duct you want to get in, these are what you should be thinking about, is these concepts that I've laid out. And just remember, when you're first starting, whatever duct you want to get in, that's not the duct you're going to get into. So, okay, that's just a rule of thumb. So basic cannulation tips for biliary is I always begin with a sphincterotome, even if I don't plan on doing a sphincterotomy. I will start with a sphincterotome preloaded with a guide wire. I like to use full strength contrast, although that may, if you ask different people, they'll do different things. The reason I like that is if I give small amounts of contrast, I want to know immediately if I'm in the pancreatic duct. If you use half strength contrast, depending on your fluoro, you may not see the contrast until you've injected a fair amount in the pancreatic duct. It only requires about a cc to overfill somebody's pancreatic duct. And we're trying to minimize the amount that we get into the pancreas. I like to minimize but not eliminate contrast. So you'll read or you'll have people say, oh, never inject, always use guide wire only, and then inject when you're in. But I think I tend to use what I would consider a hybrid technique, which is mostly guide wire, but I can use contrast, but small amounts. And I think that's helpful. Obviously, be gentle. I'll show you what this is, dock the space station, and we use a stepwise approach. So what I mean by dock the space station, so imagine this is the papilla, right here. You have to align your catheter, it may seem simple, directly in line with the other, with the axis of the bile ducts. If you're off in any sort of direction, right, three-dimensionally, you're not going to be able to dock the space station. But once you get the alignment, really, there shouldn't be a lot of pushability involved to get the catheter to go up the duct. So if you're pushing really hard, that's not the way to get into the bile duct, and it's probably you're off axis, and it can make things worse, and it can increase the risk of post-ERCP pancreatitis by creating a fair amount of edema and trauma to the papilla. We're trying to maximize cannulation, but minimize adverse events. When you get there, examine the papilla. Like I said, lead with the tip of the guide wire. I aim with the guide wire for the bile duct over that septum we're talking about. I attempt to pass the wire with small movements. I use angled wires for all my cannulations because you can torque the wire. I mentioned minimal contrast. And don't forget the long position. So we are always told, and we primarily try to get the scope in the short position, but there are some cases where you just have to use the long scope position. And if that doesn't make sense to you as far as long and short, we can talk about that at the breakout sessions or offline. You're looking for things when you inspect impacted stone, whether there's two separate openings, which you see occasionally. Is there biliary fistula? Are there tumors, adenomas at the papilla, and presence of duodenal diverticulum? We occasionally see this, where you have clearly a bile duct opening on the upper left where my cursor is, and a pancreatic duct opening on the right. So obviously you know exactly where you would want to go. Like I mentioned, fluoroscopy is useful, I think, for more than just contrast injection. It helps you define your wire passage, how your sphincterotome is vertically oriented. So if a fellow's having trouble getting in, I'll say, let's look at the fluoro for 1 second. If their catheter looks flat as it comes out of the scope by fluoroscopy, then they're actually not in the right trajectory. And it might look good endoscopically, but it's not the right axis when you look fluoroscopically. You can actually rotate some sphincterotomes, even if they're not designed to be rotated, because sometimes the sphincterotome will come out more to your right, which is more pancreatic, and you want it to go more to the left and up, so you can actually rotate the sphincterotome. There's lots of catheters and wires that are out there. I can't tell you which one to use. You'll probably end up using the one that you were trained on by your mentor, but really find out what works best for you, and don't be afraid to try or change or try new things as far as types of devices and catheters. So here is a cannulation. You can see we've put the left-right wheel, so we're going up toward that left side. We're going up high, and we used a guide wire to pass into the duct. Simple as that. All right. every time. So questions to ask, and I don't want to go into detail because really I'm doing basics. How long do we persist before we do something else? And these are all questions you have to ask yourself, but what are your second steps if you don't get in the way I described? You put a wire in the pancreatic duct with a double wire technique followed by pancreatic stent versus pancreatic stent, cannulation around the stent, and when to go to pre-tut techniques or access sphincterotomy. These are things that I'm not going to really go into detail. The double wire technique seems to be one that is very favorable or popular, and that is you can't get in, you get a wire that goes in the pancreas, you leave it there, you cannulate with the sphincterotome again with a second guide wire, and it tends to straighten out the axis. It makes your life a little bit easier, but it's recommended that when you're done, if you use the double wire technique, you should put a stent in the pancreatic duct, although I don't know what the great evidence is on that, but that's recommended by the ESGE in their guidelines. Pancreatic stent cannulation, you can put a stent in the pancreas, like I said, and then cannulate over the top of it. As you can see here, there's a pancreatic stent and we cannulated. But this is a good image also that shows you what I was saying earlier is that the bile duct goes up and to the left and the pancreatic duct goes straight back. So the two of them are different axes depending on what you're trying to achieve. As I mentioned, there's a guideline. This is actually a really good guideline. I don't know if they've updated it since 2016 on papillary cannulation and sphincterotomy techniques at ERCP. And there's a lot of really good points and tips, and they try to do grading of evidence for this. So I would suggest that you look at that guideline. The guidelines are free for both the ASGE and the ESGE, so you don't have to have I'm not going to go through all those guidelines. So you don't have to have a subscription necessarily to get guidelines. So my stepped approach is you start with a sphincterotome wire. If the wire passes in the pancreatic duct repeatedly and or I have more pancreatic injections, I generally put a wire and a stent in the pancreatic duct. I use my sphincterotome to push my stent in rather than a pusher tube. That way, when you're done deploying, you can just immediately try to recannulate with the guide wire that's already in the sphincterotome rather than a pusher tube, and then going back to the sphincterotome and changing the wire. And then I reattempt cannulation around the stent. If I can't get in, I'll do pre-cut. So let's go to sphincterotomy. Let's see. So sphincterotomy, we generally are dealing with the biliary or pancreatic duct at the major, but of course, minor papilla sphincterotomy is something we do for patients with pancreas divisum. Again, I'm going to really only emphasize biliary sphincterotomy. So we've cannulated the bile duct, as you can see on the left side, and then we've cut into the bile duct with our sphincterotomy. So one of the questions you'll probably ask is, well, how much can I cut? And if you use not necessarily your imagination, but you can see that here's the papilla, and where the duodenal wall, which is in this direction, meets the this sort of ridge right here, if you cut beyond that, you're cutting through into the duodenum. So this on the right, what you're seeing is not what we would consider a maximal sphincterotomy. And the question is, do you always have to do a maximal sphincterotomy? And the answer is no. But also it depends again on the person that's doing the sphincterotomy. Everybody does a little bit different. There are a variety of sphincterotomes available with various tip shapes, taper characteristics, diameters. The length of the cutting wire varies between 20 and 30 millimeters. Some of the sphincterotomes have an insulated portion of the cutting wire. Some are designed to be rotatable, but use of a controlled generator, which everybody uses now, is essential in performing sphincterotomy. So here's actually a case where I did a pre-cut to get in. This is an older video, as you can see, but then I went to extend the sphincterotomy. So it's really the same technique. See how I pulled back on the sphincterotome. You don't want a lot of cutting wire. You want a minimal amount of cutting wire inside. So you got to be careful about how much of your cutting wire is in. and the other is you're generating an upward cutting current. So in other words, sometimes the new fellow, I'll say, go ahead and start cutting, and they cut, but they don't. It's like putting a scalpel on a patient's abdomen and saying, okay, I'm just going to leave it there and it's going to cut its way in. No, the answer is you have to exert pressure to cut down on their abdomen. So likewise, as you're hitting the pedal, you have to have some upward pressure to keep cutting. That upward exertion of the sphincterotome can either be you're using the elevator, you're pulling back on the endoscope because as you do that, everything moves proximally, or you might turn a little bit to the left. So there's a lot of little ways, but the idea is that you have to continue to exert like an upward pressure. So we're cutting. You can see the sphincter. Most people would say stop. Now here's a good thing to watch. If you notice when I pulled back just now and bowed up the sphincterotome in the duct, it elongated the intraduodenal segment. Sorry, let me go back. So as I pull back and bow it, you see right there, it actually gives you an idea of how much you have left to cut by exposing the intraduodenal portion of the bile duct. So here's a stone that we popped out with that. Whoops. All right, let me go. So again, the sphincterotomy approaches could be, I'm going to do a maximal sphincterotomy for all patients, or a tailored approach based on size of stones. If you're going to do what's called a large balloon sphincteroplasty, not sphincterotomy. So if your thought is got a big stone and big bile duct, and rather than do a big sphincterotomy, you might do a small sphincterotomy with a large balloon dilation, which carries a lower risk of bleeding than a maximal sphincterotomy and a large dilation. We do it to allow, if you're placing more than one stent, let's say you're putting in multiple stents in the bile duct for a stricture, you may want a sphincterotomy to allow that. And in patients with PSC, even if it's one of their first ones, we often do a sphincterotomy just so because we know that we'll probably be going back on those patients. So you do it really in those cases for access. Remember, know your landmarks, the upper limits of the duodenal wall, limited wire in the duct, flexion or bowing of the sphincterotome to allow contact in the roof, upward deflection, we talked about left torque. You want to cut somewhere between the 11 and 1 o'clock position. But when you're in the bile duct with your guide wire, it's usually going to orient correctly. Like some of my colleagues say, oh, no, you got to change direction. But once you're you got to wire up the bile duct. In general, you're going to be cutting in the right direction. So again, biliary sphincterotomy is the most common thing you're going to be doing. There are a variety of sphincterotomes available. It's not a technical requirement for most stent placements. So the other thing you're here is, well, I'm doing a sphincterotomy to allow me to get a stent in. For the most part, in fact, you don't need a sphincterotomy to get a stent in. There are reasons to do a sphincterotomy when you put a stent in to prevent pancreatitis, which I won't go into, but you don't absolutely have to always do a sphincterotomy to put a stent in, nor do you always have to do a sphincterotomy to take a stone out, because you can do balloon sphincteroplasty in selected cases. So, and I tend to tailor my approach as far as the degree of incision or how much to cut based on what I'm trying to achieve in the patient. Thank you. Thanks. Is that okay? Okay. Thanks. Was it longer? Yeah. No, it was good. Oh, thanks.
Okay. Yeah, go ahead. Okay. Okay. Thanks, Todd. All right. Our next lecturer will be from Dr. Sachin Wani. Dr. Wani is a professor of medicine here at the University of Colorado and medical director of the Esophageal and Gastric Center. He is an expert in the endoscopic management of Barrett's esophagus, which is both a clinical and research passion of his. He was recently awarded with 2 NIHU grants and the ASGE Research Mentorship Award. His lecture today will be our second Dr. Brian C. Brower Distinguished Educator Memorial Lecture. which was named in honor of our dear friend and colleague, Brian Brower, who we tragically lost 3 years ago. Brian was both my Advanced Endoscopy Fellowship Program Director and mentor, and I can speak personally to his exceptional abilities as an educator. I can't think of a better person to give this lecture in Brian's honor than Sachin.
Thank you so much, Anna, for that kind introduction. All right, so here's my task. In these next 25 minutes, I'm going to talk to you about the state of the art as it relates to endoscopic eradication therapies in Barrett's esophagus. I want to start off by thanking you all for being here for this course. I applaud your commitment to education, and hopefully you'll have a wonderful 3 days here at the University of Colorado. Consistent with what's been said thus far, I too attended this course as a third-year fellow and convinced Hugo Rosen to take a chance on me, along with Raj Shah, who's in the audience. So as Anna said, we're just we miss Brian every single day, and as expected, all of us are being dwarfed typically whenever we stand next to Brian, and just honored and humbled to give this talk. These are my disclosures, and this is what I hope to cover in these next few minutes. I'm going to start off by talking to you a little bit about the importance of doing a high quality endoscopic examination so that you can actually identify patients with Barrett's related neoplasia so that you can perform endoscopic eradication therapy. I'm going to introduce these two relatively new terms called post-endoscopy esophageal neoplasia and post-endoscopy esophageal cancer, which is analogous to the concept of missing lesions during colonoscopy or post-colonoscopy colorectal cancer. I'll talk to you a little bit about the current principles that should guide our approach to endoscopic eradication therapy for patients with Barrett's-related neoplasia. I'll try and answer these two fundamental questions. What is the optimal management strategy for patients with Barrett's-related dysplasia, low-grade, high-grade dysplasia, and patients with intramucosal cancer? And how effective are these therapies in practice? I'm going to show you a few slides on how you should manage patients when you've achieved the endpoint of complete eradication of intestinal metaplasia, when you've taken your patient past the finish line. And I'll do all of this in the setting and context of recently published guidelines and quality indicator documents. So I'm going to start off with a few basics. I think all of you recognize that esophageal adenocarcinoma is a lethal cancer. For all comers, the 5-year survival rate is still less than 20%, and Barrett's esophagus is the only identifiable pre-malignant condition that we have for esophageal adenocarcinoma. Again, the reality of this cancer is that it's lethal and poor survival rates have been reported. This continues to be one of the most rapidly rising incidence cancers in the Western population. These are the most recent data from the SEER database work that was done by Sam Hahn, who's in the audience, and Jen Kolb as a part of their T32. So clearly efforts are to be made if we are to have any impact on the morbidity and mortality associated with this lethal cancer. Now let's spend a couple of minutes really talking about identifying patients who actually merit endoscopic eradication therapy. Now there's a growing body of literature describing the fact that you can actually miss lesions when you perform endoscopy in patients with Barrett's esophagus. And we introduced these two terms: post-endoscopy esophageal neoplasia, which is cancer or high-grade dysplasia that's detected before the next recommended surveillance endoscopy in a patient with non-dysplastic Barrett's esophagus. Post-endoscopy esophageal cancer is cancer that's detected before the next recommended surveillance endoscopy in a patient with non-dysplastic Barrett's esophagus. The whole idea of defining these terms is to really improve on the quality of endoscopy that we perform for our patients with Barrett's esophagus. So a logical question, you know what the estimate of post-colonoscopy colorectal cancer is. So a logical question is, how common are peak and peen in clinical practice? So this was a study that we did recently using the Optum database, and we showed that nearly 14% of all cancers can be classified as post-endoscopy esophageal cancer. These estimates are not too different from the rates described for post-colonoscopy colorectal cancer. This was work that was led by Ravi Vajravellu at the University of Pittsburgh. We then took it a step further. We decided to do a systematic review and meta-analysis of all published literature. And again, the message is the same. This entity is fairly common. In our systematic review, we showed that nearly 21% to 27% of all high-grade dysplasias or cancers can actually be classified as peak or peen, depending on the definition that you're using. So what can you do in your practice to actually reduce the rate of missed neoplasia? What you should be doing in your clinical practice is to identify these subtle or not so subtle lesions within the Barrett segment so that you can actually refer these patients or perform endoscopic eradication therapy on your own. These are just a few steps that you could use in your practice. This is what we practice here at the University of Colorado to improve on our detection of dysplasia or early cancer in patients with Barrett's esophagus. And here's a 10-step approach that you could use. The first thing you want to do is to really identify the landmarks. And these include your diaphragmatic pinch, the top of the gastric folds, and the top of the columnar-lined esophagus. Consider using a distal attachment cap. I don't have the best data to prove to you that this really makes a difference, but I will tell you, at least in patients who have a prior diagnosis of Barrett's-related dysplasia, it really helps us identify and even predict histology for visible lesions within the Barrett segment. Clean the mucosa well, use carbon dioxide, and really spend adequate time inspecting the Barrett's segment. It's recommended now that you use high definition white light endoscopy. Ensure that you're using the best endoscope that you have in your endoscopy lab to evaluate a patient with Barrett's esophagus, and recognize that using virtual chromoendoscopy, whether it's narrowband imaging or other virtual chromoendoscopy platforms, is now the standard of care. This is now a recommendation from all our contemporary guidelines. Once you've identified the Barrett segment, ensure that you use standardized classification systems. The Prague classification system to define the circumferential and maximal extent of the columnar-lined esophagus, and use the Paris classification to describe any visible lesion within the Barrett segment. Only when you've accomplished all of these 9 steps should you take out your biopsy forceps to sample using the Seattle biopsy protocol. These are the 2 most recent guidelines that have been published with regards to endoscopic eradication therapy. The first one was published through the Standards of Practice Committee, through ASGE, and the guideline below is the most recent guideline that we published a few months ago in the American Journal of Gastroenterology through the ACG. So highly recommend reading these documents when you do get a chance, but I will cover the key takeaways as it relates to endoscopic eradication therapy. So what are the principles that guide endoscopic eradication therapy in patients with Barrett's-related neoplasia? And I think this is a really important cartoon that you should understand in terms of deciding what you should do for your patients with Barrett's-related neoplasia. So if you have a lesion that actually breaches the muscularis mucosa and extends into the submucosa, these are patients that should be referred to your surgical colleagues for an esophagectomy, given the high risk of lymph node metastases. Now, granted, there may be subgroup of individuals with submucosal cancer that may do just fine with endoscopic eradication therapy, but by and large, these are patients that should be evaluated at least in our multidisciplinary clinic. On the other hand, if you have a lesion that's above the muscularis mucosa, these are patients with intramucosal cancer or those patients with high-grade dysplasia, these are ideal candidates for endoscopic eradication therapy. The risk of lymph node metastases in patients with high-grade dysplasia, 0. The risk of lymph node metastases in patients with mucosal cancer is up to 2%. So it's important that you discuss this risk with your patient before you embark on endoscopic eradication therapy. So this slide really covers the key principles for endoscopic eradication therapy. First and foremost, what you need to do is look for any visible lesion. And if you identify a visible lesion, no matter how subtle that lesion may be, you need to perform endoscopic mucosal resection. And during the next 3 days, we will talk extensively about when you should be performing mucosal resection versus ESD, but by and large, most patients can be managed by performance of endoscopic mucosal resection. The two approaches to mucosal resection, you can use the multi-band mucosectomy technique that's being shown in this video, where you literally suck the lesion up just like you're performing endoscopic variceal band ligation, deploy the band, and then use a 5 French hexagonal snare to cut that lesion out. Whenever you're doing this, you want to ensure that you resect all visible lesions. You don't want to do a resection of half of the lesion and say that I'm going to address this the next time. It's much better that you do the entire resection during that first procedure to avoid excessive scarring, which may prevent your future endoscopic resection. You want to ensure that you overlap your resection so that you don't leave any areas of nodularity between your resections. The data suggests that whether you use the band technique or the cap technique, your outcomes are similar. Granted, when you use a cap, an oblique cap, the size of the resection is much larger compared to the multi-band mucosectomy technique. Once you've resected all visible lesions, the patient comes back to eradicate the remaining columnar-lined esophagus to reduce the risk for metachronous neoplasia, which is about 30 to 40%. If you're going to do this in your practice, you need to be facile in the management of complications, which includes bleeding, perforation, stricture formation, and at least in 2022, all patients, once you get them past the finish line, achieve complete eradication of intestinal metaplasia, these patients need to be enrolled in a surveillance program so that you're prepared to diagnose recurrences of Barrett's and Barrett's-related dysplasia. Now, a few important things to remember if this is going to be a part of your practice, even before you do that first endoscopy on a patient referred to you with a diagnosis of Barrett's-related neoplasia, you need to ensure that you get all the slides from the referring physician and confirm by an expert pathology review that the patient truly has Barrett's-related dysplasia or cancer. Now, the hard reality is that our pathologists really struggle when it comes to making a diagnosis of Barrett's-related dysplasia. And it's really obvious when you look at the diagnosis of low-grade dysplasia or indefinite for dysplasia. I did this study about 12 years ago, and again, unfortunately, not much has changed. This was a study done in a multi-center format across the Atlantic, included expert pathologists here in the United States and Europe. And really the message is the same again. Our pathologists really struggle when it comes to making a diagnosis of Barrett's-related dysplasia, more so for a diagnosis of low-grade dysplasia. Why is it important for us to get an expert pathology review? Observational data suggests that when an expert pathology review is performed, you will have a change in diagnosis, and that change in diagnosis can be as high as 55%. The majority of patients that get downstage are those patients with low-grade dysplasia from the community that get referred to your expert center. Also recognize that there is a dose effect. More the number of expert pathologists that agree on a diagnosis of dysplasia, again, specifically low-grade dysplasia, the higher is the risk of that patient progressing to high-grade dysplasia or cancer. A logical question is, well, how do you define an expert pathologist, right? This has really been the subject of intense debate. So the Bolero group in Europe actually have given us some guidance on who is an expert pathologist. Anyone with at least 5 years of experience and working in a teaching hospital are important predictors for increased agreement among pathologists. What is not a predictor is self-proclaimed identification of an expert pathologist. So what do our guidelines state? Our guidelines state that before you embark on endoscopic therapy, confirm the diagnosis of dysplasia. Now let's shift gears and talk about what is the optimal management strategy for patients with dysplasia and mucosal cancer. Before we even get into the endoscopic management, you should know that there are no randomized control trials that have actually compared esophagectomy to endoscopic eradication therapy for patients with Barrett's-related high-grade dysplasia or mucosal cancer. But we have good observational data suggesting that there's really no difference between these two approaches in terms of achieving complete eradication of Barrett's-related neoplasia. It's not surprising that the endoscopic eradication group really had higher recurrences, but what's most critical in any oncologic literature is the 5-year survival rate. And observational data suggests that there's really no difference in the 5-year survival rate between these two treatment approaches. Endoscopic therapy obviously is associated with lower adverse events. So what do our guidelines state based on this literature? They strongly recommend against surgery compared to endoscopic therapy for patients with a diagnosis of high-grade dysplasia or intramucosal cancer. What about the rate of progression seen in patients with low-grade dysplasia or high-grade dysplasia? By far, the group at the highest risk of progression are patients with high-grade dysplasia. That's a slam dunk indication for endoscopic eradication therapy. That's an actionable diagnosis. In terms of the data available, we have data from randomized controlled trials and observational data suggesting that the cumulative risk of disease progression is significantly greater if you subject your patient to surveillance compared to endoscopic eradication therapy. So again, our guidelines strongly recommend endoscopic eradication therapy compared to surveillance for patients with a diagnosis of confirmed high-grade dysplasia. I'm going to spend a few minutes talking to you about the challenges that we face in management of patients with low-grade dysplasia. I can spend an entire morning talking to you about the challenges with this patient population, and this is the subject of ongoing research that I'm extremely passionate about. So what are some of the challenges? Hopefully I've convinced you that our pathologists really struggle in terms of making a diagnosis of low-grade dysplasia and agreeing with each other. We've seen that observational studies really report a highly variable natural history as it relates to progression to high-grade dysplasia or cancer. We frequently note this phenomenon of regression. What I mean by that is you're unable to confirm the diagnosis of low-grade dysplasia on your follow-up endoscopy. We still don't have well-defined risk stratification tools such as biomarkers or a combination of biomarkers to identify the ideal patient that should undergo endoscopic therapy. And I'll highlight some of the numerous gaps that we've seen as it relates to endoscopic eradication therapy. This slide just highlights the highly variable rates of progression seen in patients with low-grade dysplasia as it relates to progression to cancer, or using a composite endpoint of high-grade dysplasia or cancer. It's also important to note that low-grade dysplasia may not be such an innocuous diagnosis. These are two observational studies that showed us that nearly 25% of patients with confirmed low-grade dysplasia actually have prevalent high-grade dysplasia or cancer. So it really endorses this best practice of referring these patients to expert centers. There have been two randomized controlled trials that are powered for comparing these two treatment options of surveillance to ablation for patients with low-grade dysplasia. The first trial is the SURF trial conducted across 9 European centers, and this trial showed us that ablation reduces the risk of progression to high-grade dysplasia or cancer by 25%. If you're a purist, all you care about is progression to cancer, ablation actually reduces the risk of progression to cancer by 7%. Now, in contrast to this RCT conducted across 14 centers in France, they looked at a really different outcome, an outcome that's not been looked at typically in endoscopic eradication therapy literatures. They looked at prevalence of low-grade dysplasia at 3 years, patients being randomized to ablation or to surveillance. So it's not surprising that at the end of 3 years, the prevalence of low-grade dysplasia was obviously lower in patients who underwent ablation compared to surveillance, and patients who underwent ablation had higher rate of complete eradication of intestinal metaplasia. Interestingly, compared to the SURF trial, there was no difference in neoplastic progression between the two treatment arms. I will tell you that the rates of complete eradication or prevalence of low-grade dysplasia are far different from any of the literature that's been published here in the United States or centers outside of France. They also noted that there were significant differences in outcomes based on what your individual volume was at the treating center. Again, going back to my point of ensuring that these patients should be evaluated at expert centers. So there's some obvious gaps. I've just shown you two contrasting randomized controlled trials. You should also note that the high rate of neoplastic progression seen in the surveillance arm in the SURF trial, these are estimates that have really not been seen in any observational data here in the United States. We also know that if patients are followed appropriately, surveillance arm patients actually do reasonably well. If you have them under surveillance, you will identify those patients that actually progress to high-grade dysplasia or cancer. Let's not forget that endoscopic eradication therapy is associated with an adverse event rate that can be as high as 20%, and none of these trials have actually, again, evaluated contemporary biomarkers, nor have they actually taken patient-centered outcomes into their decision-making. So to address all of these knowledge gaps, we are now ready to embark on this large multi-center randomized controlled trial, the SERVANT trial. Incredibly grateful to NIH for actually supporting this study that will be conducted across 21 centers. So wherever you practice in a year or two, if you're practicing at one of these 21 centers, try and enroll patients into this study. If not, identify a center that's close to you so that you can send these patients to us. What will this randomized controlled trial do? This will basically involve patients being randomized to endoscopic eradication therapy or to surveillance. And of course, our primary outcome for specific aim-1 is neoplastic progression rates between these two treatment arms. A novel aspect about this RCT is really taking into account patient-centered outcomes and the fact that we will be evaluating contemporary biomarkers to identify that patient with low-grade dysplasia who is at the highest risk of progression to high-grade dysplasia or cancer. So until we get the results from the SERVANT trial, this is what you should be doing for managing patients with low-grade dysplasia. It's really important for you to take a patient-centered approach. While you can offer endoscopic eradication therapy, recognize that for a patient who really places a high value on avoiding adverse events, surveillance is a perfectly fine treatment option. Lastly, I just want to share with you some data on the effectiveness and durability of our current approach to management of patients with Barrett's-related neoplasia. Several observational studies have demonstrated the effectiveness, and these are all data from trials outside of the randomized control trials. If there's one study that you should know about, this is the study that you should focus your attention on. Again, from the Amsterdam group, demonstrating outcomes for endoscopic therapy across 9 centers, and they included close to 1,400 patients. What they showed us was that the durability rates are pretty amazing, at least when treated appropriately at these expert centers. The vast majority of patients can achieve complete eradication of intestinal metaplasia. Recurrence rates are low, and these are estimates that you could potentially quote to your patient. Recurrence rate of any dysplasia is the annual risk is 1%, and that for high-grade dysplasia or cancer is 0.7%. Just a slide on alternative ablative therapies. There's again a growing body of evidence for these newer ablative techniques that really use cryotherapy or hybrid APC. We obviously need more data, and my take on these newer ablative techniques is the fact that we need non-inferiority randomized control trials that really compare these technologies to our standard of care, which is EMR and radiofrequency ablation. Just one slide on how you should be managing patients who have achieved complete eradication of intestinal metaplasia. As I mentioned, these patients need to be enrolled in surveillance programs. When you bring these patients back, the concept is the same. You have to use the best endoscope you have, high definition white light endoscopy and virtual chromoendoscopy. Once you've taken a good look, and it's important to remember to perform good retroflexion and really taking your scope into the hiatal hernia sac so that you can get a good inspection of the gastric cardia. Recognize that recurrences in that area are by far more common than recurrences seen in the distal esophagus. Once you've done that, take biopsies from the distal 2 centimeters, and when you bring them back is really based on what your baseline histology is. If you find a recurrence, manage it like you would manage any patient with Barrett's-related dysplasia. In rare instances, these patients may require surgery if the patient has progressed to invasive cancer. If you're going to do this in your practice, you need to recognize that quality indicators have been established for endoscopic eradication therapy, and these are indicators that have been endorsed by the ASGE and ACG. So this is my final slide on practical tips that you can use to improve endoscopic eradication therapy outcomes. Again, want to emphasize the importance of centralization of care for patients with Barrett's-related neoplasia. Ensure that treatment is being performed by trained endoscopists at a center with a high volume of cases. Ensure that you have expert pathology review, and ensure that you have access to multidisciplinary care. Take enough time inspecting the Barrett segment using high definition white light endoscopy and virtual chromoendoscopy. You should really have a low threshold for resecting any visible lesion within the Barrett segment, and your treatment should be performed under adequate acid suppression. And enroll these patients in surveillance programs after you achieve complete eradication of intestinal metaplasia. I just have one word of advice for all the trainees in the room. I think it's really important that you're mindful about the first job you select. I'm sure during the question and answers, we'll talk a lot about this. There are not too many people who can say that they work with some of the world's best endoscopists and the best nurses. Thank you.